Good morning again, everybody. I know we have a diverse audience today. We have nurses from the ICU and the ER, right? And our stroke unit. And then we have some flight crew folks. So it's hard to sort of talk to everybody. You all have different needs when it comes to some of this stuff. But let me introduce myself. I'm Dr. Franz. I'm the medical director of stroke here. I'm the director of the NeuroICU down at Banner University. I'm the stroke director at Estrella. I'm the clerkship director for neurology. And now that I've built myself up, we will tear me down. So I don't know if you guys saw this. I guess it was near the emergency room, but I like the man bun right on my bald spot. I appreciate that. The monobrow of power. I really like that. So today I'd like to talk about the NeuroExam, and hopefully this can be a practical value to you. And we're going to specifically talk about the NIHSS stroke scale, but everyone has some different needs in the audience here in terms of what you'd like to get out. The more you understand about the exam, I think the more interesting neuro might be to you. And I think a couple of the key principles will be, how do we get answers out of people who are not answering us? Whether that's somebody in an ICU on a ventilator or somebody who's cooperative. And maybe we can teach a few other things too along the way here. So just a little bit of background. When we say stroke, it's a historical term that referred to being struck down by the hand of God, which is a little bit mean. We learned a little bit since then. And it encompasses a lot of things. So when we say stroke, it actually includes subarachnoid hemorrhage, which is aneurysms rupturing in the head. It includes hemorrhagic stroke, where small vessels rupture within the tissue of the brain itself. So in the upper right there is a hemorrhage within the substance of the brain. And then of course ischemic stroke. And ischemic stroke is where clots or plaque or both block blood flow to the tissue and the tissue dies from lack of oxygen. It's very analogous to a heart attack, a myocardial infarction, in the sense that the heart muscle loses blood flow and it dies. And in a stroke, it's the brain tissue that suffers from a lack of blood flow. And that's what I tell my patients, and hopefully that clarifies things, but it's confusing. Aneurysms are so different than an ischemic stroke. Now, I've been lucky enough to be along the ride for the last 6 years at Banner University, and we have the Comprehensive Stroke Center designation, and that's the first and only in Arizona, actually. And as a system, we do something like 55% of all the stroke care in all of Arizona. And when you compare our facilities, including yours, we're exemplary in terms of our data and our metrics, which is hats off to you and Sharice and so many people that have helped over the last few years. So it should be a point of pride. And when it comes to these catheter procedures that are all the new rage, we destroy everybody in the entire state in terms of the numbers that we do. So that's been a big source of pride. It was a surprise to me that Barrow wasn't doing more of this, but they do maybe 1 or 2 a month, and we're at 70 for the year, as an example.
Over 16 to them.
Yeah, and your population in particular, retirees, a lot of folks who have atrial fibrillation in particular, tend to have these big bad strokes that can respond to catheters. And we can't fix every stroke, but we can work some miracles in some folks, and we can keep people independent even if it's not perfect. So I just have to say, it's all your efforts. It's our flight crews, it's our EMS, it's our ER process, it's on the stroke units. All these things are really important. So why do we do what we do? Well, the principle is the blood flow is getting blocked to a portion of the brain tissue. And that central area we might call the core of the infarct. And that's where the tissue is going to die. And we may not be able to salvage that. And then around that area, there's this theoretical thing called the penumbra, which is salvageable. So if we restore blood flow fast enough, we may save that. And then beyond that area, blood flow may be just low enough to cause problems or neurologic symptoms, but won't result in a permanent stroke. Actually, that didn't quite, there's one more animation. The idea is if we don't intervene on these people, then the stroke will be much larger. Sometimes we do knock it out of the park. We just discussed a case today that had IV TPA, and we got rid of a clot, and the gentleman walked out of the hospital, and it will probably be normal in the long run. And with these catheter procedures that I'll touch on briefly, that's a really important part of the puzzle, and it has so much to do with our flight crews and our EMS and our ER process in particular, but the more folks know, the better. So just a couple of things about thinking about how long we have the people in the hospital and the general time frames. Well, for IVTPA, that's the second one down, the red one, up to 3 hours is the standard across the board for everybody, and then between 3 and 4.5 hours, we can give IVTPA with slightly stricter criteria. The number needed to treat, which is a nice number, is 4, meaning we can have people with an excellent outcome by giving TPA in the first hour. And if you give it to 4 people, one of them will have an excellent outcome or be normal. And as much as 50% of the people who get TPA actually benefit from the TPA. That may mean going from a severe stroke to a moderate, or a moderate to a mild stroke. So it's always worth it. And it really is the golden hour is the point. When you look out to 3 hours, the number needed to treat is about 7, meaning we need to treat more people to get that really, really good outcome. And the sooner we get people in, the more they know, the sooner we get them to any therapy, the better they will do in the long term. So other interventions is an evolving area, and this is where our flight crews play a big role. And I'll talk about what we're doing at the state level briefly, and then we'll get into the exam. But the idea is we have catheter procedures to pull out the largest clots in the brain. They're right at the base of the skull, and they tend to be very large strokes. And I think several of you know that. These are the people who can't talk. Maybe they're blind to one side, they've got horrible neglect, they're paralyzed. These tend to be big, bad strokes. We can't get the catheters out too far in a lot of people, so we can't grab smaller clots, and it's not clear that risks of these procedures are worth it if it's a smaller clot. But for now, and in select cases, we can pull clots out. When you look at the guidelines across the country, it suggests between 0 and 6 hours, we might consider a catheter procedure. But the truth is everybody is different. So for a stroke alert process, that makes a lot of sense. But the literature is evolving. So some people are just lucky enough to have other avenues of circulation to the brain to keep the brain sustained for a longer period. And we might be able to pull a clot out 12 hours after it started. Other folks will have a complete massive stroke within an hour's time because they don't have that collateral circulation, that extra blood flow to keep the brain healthy. So that's an evolving area. I think if we called stroke alerts up to 24 hours, it would be extremely burdensome. But it takes a little insight and knowledge, and so we pick and choose winners with the clinical picture and with knowing where the clot is and knowing how much brain tissue is injured or already dead. So if there's a lot of injury, we may abort a catheter procedure as an example. Same idea with TPA. If it looks like there's nothing to save, then it's probably not worth the risk. The risks of TPA, well, if you look across our system, even the risk of serious bleeding inside the head is something like less than 2%. Less than 1% in most places, which represents a huge improvement over the last 20 years. And a lot of that has to do with process, making sure the blood glucose is in target, making sure blood pressure is in target. And so all these things that happen on our units are really relevant to keeping the risks down from the procedures and maximizing benefit. When it comes to catheter procedures, we quote about a 10 to 15% complication rate. So you're shoving a wire up in the brain and you're trying to pull these clots out or disrupt them or suck them out. And you might perforate an artery. You could cause a dissection on your way up and injure the internal lining of your artery. So these things are not risk-free, and that's why we can really only do them in these really, really big strokes. And so before we get into the exam stuff, where are we going in Arizona? Well, we're going to have a meeting. So the stroke leaders have been getting together, including the stroke coordinators from most of the programs across the entire state for years. So years ago, some of the Mayo stroke people started this collaborative where we get together. And we've been moving in the direction of improving care as best we can. So the reason we have EMS diversion in the first place to primary stroke centers is a result of that collaboration. And there's state bills that have been passed that are sort of pushing us even further forward. And I'm sure all of your directors are aware of the politics involved, and same is true for EMS. So the first piece of that puzzle are these large vessel occlusion scales. These are clinical scales that are meant to pick out these patients who likely have one of these big clots that is amenable to a catheter. And so we need to do one of two things, and these are the two. There's what we call mothership and drip. And the idea is that if we see a big stroke, maybe it makes more sense to divert to a comprehensive stroke center. And for now, again, the state only has one, but Mayo and St. Joe's do catheter procedures as well. So it's sort of self-assigned, but we will tighten that up as we go. But these are used in the field and meant for EMS, and I know we've implemented it here. It's not quite system-wide yet. The VAN scale is homegrown, so Dr. Taleb, who's an interventionalist at Desert and at university, came up with this scale, and it's being adopted actually in a lot of places. And the beauty of it is that you don't need to think like a neurologist or a neurospecialist or a neuro nurse, meaning it's a bit more implementable, and it's either positive or negative. And so I know that's what we've done on this front here. So CT angiograms have slowed things down, but when EMS brings in these folks or they come in by POV, everybody's going to get a CAT scan, right? We want to know if there's blood, number one, and if there's injury and how much. And with these scales, when they're positive, we suspect a clot that we'll see in these big pipes, and that's why we do these CT angiograms. We've gone to direct to CT, which so far has been a resounding success. We see improvement in our numbers, and so our ER staff, thank you for being so compliant. And the entire system is going to go this way with a little bit more time, and probably all of EMS deployed, at least in the Phoenix metro area, will be trained for these types of scales to help figure things out. Right now they use the FAST scale, face, arm, and speech, and that's either positive or negative, and that's how the patches get called into the emergency room. And so we'll imagine patches getting called in where they say it's FAST positive or VAN scale positive, and there's several other scales. And we'll know that we want to look at the pipes early to see if there's a really, really big clot in those people. And so hopefully we'll hone in and we will really help a great number of people. And a lot of them come from Sun City and Sun City West and Surprise and such because of the retirement communities. What causes those strokes, by the way? That tends to be atrial fibrillation. That's a very, very common cause. And a lot of carotid disease can cause similar large clots. A lot of other strokes are much smaller, for the record. And atrial fibrillation, it's millions of Americans, probably something like 6 million, who have this, and most of them don't know because it's paroxysmal and not everybody has symptoms when they have it. And so the older your population, the more likely you are to have atrial fibrillation. And so that's why in these retirement communities, we see a lot of that type of disease. So it's really important. And Del Webb has been instrumental in helping these people in the long run. Okay, so we'll figure out that diversion stuff. At some point in the future, we're going to have discussions in the next few months here about that. And that's a collegiate thing, mostly, where the stroke specialists from across really the entire valley will get together. But I will plant this one seed. I'm not in favor of EMS diversion to comprehensive stroke centers yet. The data suggests we help people more. That means people will be diverted from your emergency room and other hospitals. As soon as I say that, our administrators get a little nervous because it has financial implications, right? And ER docs like to see complex disease, and so do the nurses, even if it means they're going to get out. But you stabilize them, you save a life, you put them on a ventilator and such. I think we can do better. We've done massive things across the state and at all of the primary stroke centers. So I think there's only 2 hospitals left in the general Phoenix area that are not primary stroke centers. And we've elevated the care across the state. We're one of the top states in the nation, like top 4 consistently in the door-to-needle times and such. And so we've really done good. So my contention is that if we get our door in and door out process down very low, it'll make up for any deficits, and it means better care, I think, in a lot of ways. I don't want to remove patients from hospitals. There's a lot of politics involved. But that's how we do it. That's how we prove that we can keep all of these patients at least coming here initially. You give TPA, and Therese has rolled her eyes when I've said this, but my stretch goal really is 45 minutes to get these people out, these catheter patients. 60 would be good. That's my personal stretch goal. That sounds crazy, but if you think about it, you get called in with a VAN positive scale, so they're likely to have a clot. They get a CT angiogram, and we know there's a clot very early. Radiologists will have to suck it up and call real quick and say, hey, it looks like there's a clot. They can read the rest of the study later if they want to, and we'll work with them, of course. And then the ER doc can pick up the phone and call me or any of our colleagues 24 hours a day. We look at all of the scans, we make some clinical decisions, and we could have flight crews here within, a few minutes, generally speaking, and out the door very quick. And all of the flight crews are extremely efficient when we look at the data. So hats off to you for that. So when we go, where are the delays? It's never in the flight crews. It's, the ER doc doing something. So that's where I'd like us to get in the next couple of years optimally. And it may help keep business here and keep you engaged and help people rather than steering them away. But we are fighting a lot of politics at the state level. So I'll plant that seed. So I think we're doing really good and we're starting to look at these numbers. It's really an important thing. Today I'd like to talk about the NeuroExam in general and maybe answer some questions. People wonder what I see. Now the NIH stroke scale, is anybody not certified, or are you guys certified in the NIH stroke scale?
I'm certified, but
okay.
not.
It's not particularly helpful for you guys, but I think the rest of the staff is, right? So you've all gone through that awful training from 1992 with those terrible videos. So the first point I want to make about this scale is the doctors in those videos are really old now, and they don't want to replace the videos because they want to remember themselves as being young. The reason the NIH stroke scale became widely adopted is because it was the stroke scale used in the original TPA studies that were positive for stroke. So it simply became widely implemented. Is it perfect? Not even close. So it's meant to be a disability scale, an acute stroke disability scale, but we use it for other things too, like prognosing how somebody might do. So for example, a score between 0 and 3 is mild stroke. They're very, very likely to do very, very well. Between 3 and 16 is considered a moderate stroke in terms of disability, and above 16 is considered a severe stroke. Bleeding risk is dictated by this in part. So the bleeding risk above a score of about 20 might be as high as 17%. And that's old data, mind you. And we treat those patients differently today with catheter procedures and such. But it's less than 3% in the mildest cases, so very low. And when I told you our numbers across the state, generally speaking, and all of the Banner facilities are very, very good. So we've fought this historical concern of bleeding risk with TPA. When you look practically at the data, though, it's extremely safe. And we'll give it at times to people who don't even have stroke because it looks like a stroke. And so we call those folks stroke mimics. And people can be very, very good at either pretending they have a stroke or subconsciously having stroke-like symptoms. And so if you've been in the ER, I'm sure you met some of these folks. It's pretty impressive. And then there's other conditions that may mimic stroke, right? So a very low glucose might present with weakness on one side of the body, something like that. Somebody who had a seizure recently, and we found him after the seizure, what's called Todd's paresis. So there's other things that can look like stroke. The good news is whenever we study these people, it's extremely safe. So if you don't have a stroke, you're not going to bleed into it very likely. So capturing these people with these scales is very important. A modified NIH stroke scale was developed actually, but it wasn't implemented again because of the historical correlation. So it's not a great scale. I hate the training. It needs updating. So I'm not going to pretend it's perfect, but it's a tool. We know that every point lower over time, people are more likely to be discharged independently. And so you can look at these kinds of numbers and make broad statements. I'd say, generally speaking, a point up or down doesn't mean too much in most cases if it's a higher score. We're not looking for perfection. The question we're really trying to answer in the emergency room is this disabling in any way? And so we could argue, well, some tingling on the left side of the face is probably non-disabling. They'll probably be fine in the long run. And that's really the question we're trying to get at. But it's a good starting spot. And so the more accurate we are, the more we can look at discharge NIH stroke scales and say, hey, this is what we've done. But there's a lot of variability. So which doctors are the best at using the NIH stroke scale? Do you know? Hint, it's not neurologists. It's ER docs, actually. So they tend to be, because they follow the rules better. And the neurologists, we think we know better. Well, we do kind of, but for the purposes of seeing who's accurate. And ER nurses that use it a lot, and nurses on the stroke unit and ICUs who use it a lot tend to be very good at it. However, if you're only seeing people who are awake and cooperative, you'll probably be very bad at getting an NIH stroke scale on somebody who's comatose or fully aphasic. And that's not a problem. And so I'd like to highlight some of that today and maybe talk about what it means in terms of the exam. So just some resources that you can find, short of talking to Charisse or somebody who has more experience with the scales. There's several online things that I would highlight for you. This is the NIH Stroke Scale booklet, and this is a nice reference. So if you just Google it, you can find it. And I mean, we could make it even part of the stroke packets if we wanted to. So when you're confused about how to score something, you can just sort of jot something down and maybe come back to it later and try to answer the question for yourself. And we've got a little bit more detail in this. And so I like this as a reference for people. It's nice, and it also has the pictures here, of course. And then here's the quote-unquote long form. And this is also a good reference, and this is in our stroke packets, right? So this answers some questions, but even if you go through the training, a lot of the key points are not really well specified, and nobody's going to be perfect. When I see a patient who's complex, I will go back to these resources to make sure I'm accurate. And if you're unlucky enough or lucky enough to have a purely comatose patient, it really changes things in terms of how you're scoring. The logic is inconsistent. So some things you have to see. So like ataxia, and we'll mention that, you have to see that in your patient. So if they're paralyzed, a lot of nurses will say, score them for things like ataxia. But if you're not moving and you're not clearly ataxic, it's hard to score. So what I'm saying is it's a terrible scale, it's poorly taught, and it's difficult to implement. And so recognizing that it can be challenging at times, I think is helpful, and I think it's honest. And I think we could probably publish a paper looking at accuracy these days and annoy a lot of other people who made these scales originally. But even those folks, again, will admit it's imperfect. The last resource I want to point out to you real quick is MD Calc. And so this is an online free thing. There's also an app for it. And there's a lot of nice scales in here, clinical scales that are really interesting for nurses. And so there's nurse-specific scales and doctor scales. And if you just search NIH stroke scale, you come up with this. And this allows you to electronically calculate it, which is nice, where you just sort of click on something and it'll add it up for you. So you don't have to add, although I'm sure you're all very good at that. Okay, so let's talk about each individual item here and then maybe highlight some exceptions. So level of consciousness, I think we score this one generally pretty well. They're either awake, a little bit sleepy, right, or obtunded, or comatose. So those are the options. 0 is keenly responsive, arouses to minor stimulation. I think most folks have no problem figuring that out, right? I mean, they either interact with you or they don't. And someone who's like obtunded and you have to sternal rub them to get them to interact, you might score them as a 2, okay? And posturing, so when we say posturing, this is something when I'm teaching the students and residents, we like to talk about. So when I'm rounding the neuro-ICU, somebody may be paralyzed on one side of the body and I give them a pinch in their limb and they may do this kind of thing. That's a posture, but it's not decorticate. So I think all nurses in nursing school learn about decorticate posturing and decerebrate posturing. They're both really bad. And that's the reason why the Glasgow Coma Scale has sort of extension posturing. But when it happens on one side, we might just call it, it's not decorticate and it's not decerebrate. Those words imply everything on both sides is not working, and that's why they're having those motions. That's somebody who's herniating. The brain is swelling so bad, for example, that they have those kind of postures, and they'll be intubated and comatose. So posturing, again, in the sense of decorticate or decerebrate or unresponsive. Coma means you are not interacting with the world, you're not responding to stimuli in meaningful ways. None of the parts of the brain that really matter are working right. Memory, communication, vision, sensation, thought, all of those big things. That's what a coma means. And if we do click 3, it'll trigger a few other automatic things, and I'll come back to that. And 3 really means coma, okay? No one's gonna be awake and posturing on both sides of the body. It's just not physiologically possible. So I think people do very well with that one. When it comes to 1B, these are the 2 questions. And if you're comatose, this one's easy. You're going to score a 2, right? And even if you have trouble with language, but you're awake and you can maybe mimic, you're not able to answer these questions. That one's pretty easy. So if you can't talk, you're going to end up scoring a 2 on this case. Now, it's always weird when they're intubated, right? So in the ER, they may get rocuronium. and be paralyzed. That's not a fair NIH stroke scale assessment, but when they're not sedated and they're not paralyzed, that's an opportunity to examine them and try to get a more accurate number. So it's helpful, but it can be very hard. A language barrier, right? So if there is, if somebody's not speaking English, for example, this is one of the times where we're allowed to sort of go outside the normal bounds and maybe ask in a different language or a different fact. And so as a neurologist, I may do that as well. So generally speaking, I think people do very well on this one. You either can answer the questions or you can't at the end of the day. And if you're intubated, again, you'll actually score on this one. But a 1, so not really logical, right? So in a phasic patient that can't talk and answer the question, it's not getting it right. Now, if you have a urinary tract infection or you're septic and we're not sure it's a stroke, people are going to score on these questions. So already we're going to classify people who don't have stroke, who are encephalopathic and confused, or maybe they had a seizure or something like that. So highlighting again some of the weaknesses here. So blink eyes and squeeze hands. I'm going to go back to this one. I think this one talks to it about a little bit better. So here's our commands, right? Okay. So this is one of the cases where mimicry is okay. So to a neurologist, mimicry is not the same as following a command. If you can do things like have people write in cases like this. The same way you can check language, you can substitute things. So if someone was unlucky enough not to have arms, they're not going to be able to make a fist, or if they can't move it for other reasons. And so you could wiggle your toes, you could stick out your tongue. And so it's just 2 commands that you'd like to use with the patient. And that's pretty straightforward, again, except for the exceptions, which are always challenging. So closing your eyes and making a fist, though, pretty easy. Interestingly, midline commands are much easier if you're confused. So something like sticking your tongue out or closing your eyes is far easier than the gold standard in an NeuroICU, which is show me 2 fingers. That's how you really know somebody understands you, when you can do something a little bit more complex. And you can show them a fist if they don't respond to the question originally. In this case, you can close your eyes tight, and it's okay, although to a neurologist it means very different things. I can get my dog to mimic some of my movements sometimes, and so that's not high level, language comprehension necessarily. That's kind of the point. But for this case, we can coach a little bit. And again, this is some of the inconsistent logic, and I'll point this out and remember where the references are if you're confused. Okay, and our next one is the gaze, and this one I see a lot of difficulties for people. And so what we're looking here for is full movements horizontally, right? All the way from the left to the right. And there's a few tricks you can do, even if they're aphasic and they don't understand what you're saying. So some people with these big strokes in particular, if you hurt your frontal lobe, you'll have a gaze deviation where you look towards the stroke. In fact, it's part of the Van scale, these big scales looking for these big strokes. And so if someone's eyes are glued like this, now you can ask them, and maybe if it's an injury on this side, they'll be able to understand what you're asking, and you can say, can you look to the left side, right, if their eyes are glued to the right side? And they either can or they can't, but you should always check with a reflexic maneuver. So what is that called? Anyone know? How do we check the eye movements if they're not compliant or comatose? So people talk about doll's eyes. You remember that one? Right, and so you don't want to snap their neck, and you can do this gently, mind you. But doll's eyes means this, so I'll fix my gaze here, and so when I turn my head this way, the eyes move, and that tells us something about the health of the brainstem and the rest of the brain. It's a complex conclusion, but if you go past midline, then it's going to be scored in the middle range, right? And if it's complete forced deviation, the eyes never move no matter what, then that's going to be scored a 2. And one of the other tricks that I learned a long time ago is the brain is primed to make sense of what it sees. And so recognizing a face, for example, the brain is really good at, and perhaps this is why we can see Elvis in a piece of toast or a face in a cloud, because our brain is honed in on these things. So if you ask somebody to look at your face and you go, look at me, look at me, look at me, and you walk around the bed, oftentimes they'll follow you actually, whereas if you say just look to the left, they have trouble doing that. So we're honed in on faces. We're social beings, and we need to communicate. And if somebody's angry, we want to be able to look at their face to know we should run away in the primal sense. And so that's another trick you can do, okay? And so if they come in and their eyes are closed, and I've seen that one before, they're like, their eyes are closed, I can't check. No, what we do in the ICU, right? We hold the eyes open, same when we're checking pupils, and then we do these gentle maneuvers here. And so there's a lot to learn from that. And so this is one of the tricks you need to have in your toolbox to really score this accurately. So visual fields can be tricky. 3 for visual fields is very rare. A bilateral hemianopsia, that is blindness, okay? Hemianopsia means half of the world is gone in both eyes. And so if it's on both sides, you are blind. So we almost never see that. It is possible in rare cases. I saw a drug mule, unfortunate young person who swallowed a bag of methamphetamine and ended up having a terrible stroke where both of their visual cortices were destroyed by stroke. And that was one of the few cases I can remember where somebody was actually blind but awake and interactive. So super rare. So the more common thing we'll see is the hemianopsia, which again means half of the vision. And in the videos, they do this, how many fingers am I holding up business. I think that's not optimal, actually, and so I would steer you away from that. It's fine if it works. You should use yourself as the control, though. So my students, and I'm just going to demonstrate here real quick. So when I'm talking to students and they're learning the neurologic exam, for example, they'll do this kind of thing, and they'll go, where is it moving? You're really checking center vision here, though. So if you use yourself as the control, you put your fingers about halfway between you and the patient, you're really checking those corners. So the most information will be obtained when you're really hitting the corners of that, of your big square, if you will. It's really circle, I suppose. And so I think the better test actually is a finger wiggle. And it makes noise, so if you have gloves on, you may clue them in, mind you. But if I say, where is it moving? They're going to look to one side and say, they'll point, right? Or they'll say which side it's on. I say point because it's even easier. If they go, it's left, but it's my right, they get confused, that kind of thing. And one of the important pieces here is we're checking for neglect as we go along in our patients. And neglect, you may hear as inattention, and that's how it's listed on the NIH stroke scale. And this is one of the important pieces. And so you can do the fingers again, but if they have cataracts, that's like half of our population, right? Or just bad visual acuity, they don't have their glasses on, it may be hard for them to actually see how many fingers you have up. That's why I think a finger wiggle is a little bit better. So if somebody's comatose or poorly responsive or can't answer your questions, how are we going to figure out how their visual fields work? How do we do that? Anyone know? Yeah, we do a blink to threat. And so that works pretty well. So even in an aphasic patient, you can often come up, and we just do it from one side or the other. And they may blink from the good side, right? And then they don't blink from the other. That's going to be a 2 typically. And this is what we do in the ICU, again, or if people are confused. And it's highly accurate, actually, because it's a primitive reflex. And so if you don't have vision and you can't be aware of these fingers coming at you, if you do this kind of thing, you may actually send enough air to the eye to make somebody blink. So I do like the sort of finger poke maneuver. I did poke someone actually by accident once, and I regret it. So don't do that. But again, we can get an answer to this question. So extinction, does anyone know what extinction means, by the way? So I mentioned neglect. So let me address what that means. It's very confusing when you tell families and patients about neglect. Some people get offended, right? And again, it's also known as inattention. And so injuries, particularly to the right part of the brain back here in the parietal lobe, can cause a neglect. It's a spectrum of symptoms. And you have to know about this a little bit, and a few of these things we'll check for it all along. So in its grandest form, it's called, hemispatial neglect. And people will actually look away completely because their brain is ignoring, say, the right side of the world or the left side of the world. And they won't even recognize their own body part. And so if I think somebody has neglect, one of the quickest things I do is I hold up the weak side or the side they're ignoring, and I go, whose hand is this? And universally, if they have terrible neglect, they'll say it's yours. And I'll say, hey, look at this wedding band. Does this look like yours? And they'll be like, yeah, that looks like mine. And how about this tattoo that says, I love Bob? And they'll say, yeah, no, I have that kind of tattoo as well. And I'll go, is it your hand? And they'll say no. And it's an amazing thing to see at times. That's the most severe form, though. And so we don't always see that, but you can. And again, it's from injuries usually to the right side of the brain, although it can happen on both sides. In its mildest form, we have what's known as extinction. And so what does that mean? So when I'm checking visual fields, I'm going to do one side, and then I'm going to do both sides. And you're going to say, where do you see it? And if somebody, I'm going to use you as an example again. So if somebody has a visual neglect, their vision system's okay. They really shouldn't have a field cut, or they might have a field cut at the same time, meaning impaired vision. So if we do this, and she says left, and then she says right, and then I do it together, and she says right, then I do it together again, she says right, then I should see this, on the top and the bottom part. So it looks like when I challenge the brain on one side at a time, it's smart enough to recognize that stimulus. But if you have neglect or inattention, it'll ignore it when challenged. And so we extinguish that side, and that's what extinction means. And that's why you see it here on some of these scales. And so that actually scores a 1. So very hard. That one's tricky. Usually you'll see several modalities of neglect. So you can have vision neglect. You can have, again, hemispatial neglect, even not recognizing a body part. And then you can have tactile neglect or sensation. And I'll try to come back to that again. So it's a fascinating symptom. And I just saw somebody in clinic yesterday who still had a little bit of that, although they look great. So it can be very mild and very subtle. And so that's one of the more confusing areas for folks. If you see a lot of things, somebody might come in, by the way, with a big subdural hematoma and look like a big middle cerebral artery stroke and score on all of these things just the same. And it's not a stroke. Somebody could have a tumor on one side of the brain and have a seizure, and then that part of the brain is very tired, if you will, after the seizure, and have all of these findings as well. So that's a big one, though. It points to the outside of the brain when you see neglect. That's why it scores on the Van scales and these other scales, because we expect large portions of the outer part of the brain to be suffering in these large clot things. Okay, so hopefully that makes some sense. So 3, again, you pretty much never see. Most people will score a 2. If you find anything less than half of the vision involved, then it would be a 1. So we could call it a quadrant synopsia, for example, if we think just one quadrant of that circle is affected, or if it's partial, you would just score a 1. But a 2, again, will be everything to one side, okay? You can already see, I mean, some people probably came into the lecture and they thought they were pretty good, but there's a lot of subtle exceptions here. So it's good just to be aware of them and know where to find a reference, and that's really the point of this talk. So facial palsy. So not everyone is Brad Pitt or Angelina Jolie or Emma Stone with perfect symmetry to their face. Some people are asymmetric. Some people will have like kind of a slack jaw, right? And if you push them this way, it looks like they've got a facial droop. And if you push them this way, it's suddenly on the other side. I've seen that a few times, right? And so the subtlest thing you can look for on a patient is really the nasolabial fold. And that's from the nose and the naso to the labial, which is the lip. And so in folks, we'll have a well-defined line at times. Not everybody has those lines, mind you, but if you're looking for subtle facial weakness, it may be flat or blunter on one side, and that's what a 1 is. If you think it looks asymmetric, go ahead and score it a 1. I've seen plenty of people where I don't really think it's a facial droop, though, and again, not everybody's perfectly symmetric to begin with. And that's what we mean by a 1. So flattened nasolabial fold or smile asymmetry. A lot of people don't smile very symmetrically, too. Some people smile to one side, so it can be hard. The most common stroke is a lower facial weakness. And so what you're almost always going to score when the face is weak is a 2, actually. And that's from here down. So if somebody comes in with a Bell's palsy, I'm sure you've seen plenty of these in the emergency room, they're going to have facial weakness here and here. So you ask them to raise their eyebrows, right? And they'll be paralyzed on that side. And so weirdly, a stroke looks like less weakness. It has to do with the wiring. And a Bell's palsy is an injury to the nerves, so not an uncommon thing to see in the ER. And an astute ER doctor will pick up on that right away. But I got to tell you, I've seen Bell's palsy treated with TPA, and it has nothing to do with clot. And so it can be confusing, especially if you're not seeing that kind of thing a lot. And so most strokes that truly have facial weakness will end up being a 2. And a Bell's palsy will be a 3. even though it's not a stroke. So you can have a brainstem stroke that causes paralysis above the eyebrow and below. It's just rare. So it is possible to hit the 3 when you hit where the nerve comes out in your brainstem way down low. I have seen people with bilateral facial paresis or weakness, and they tend to have just an agape mouth and they can't move their face. And you're not getting any reactions from these people. And it can be hard to tell, but we might call it facial diplegia or paralysis on both sides. Again, super uncommon in most ER settings or otherwise. And it's both sides, so it can be hard to tell. So my next question is, how do we know when somebody's not answering questions or we can't get them to smile? How do we know where the weakness is? How are we going to figure that out? So this is another time when you're going to have to be a little bit mean. You can shake the patient, you can give them a sternal rub, you can do a nasal tickle. So that's one of my favorites because it doesn't leave bruises and it doesn't hurt people. I shove a Q-tip up the nose and it's very, very irritating. And then they'll do this, right? So if their face is strong, they'll grimace on both sides. Same, and smelling salts are the same thing. You're pissing off the mucosa in your nose. It's a bit of a reflex, but you could do the same thing in the field and see. I'll give a trap pinch in somebody who's, obtunded or comatose, and I'll just squeeze the trapezius, that kind of thing, and then you're looking for a grimace. So this is one of the times where, again, it may not be so obvious, but you have to stimulate your patient. And this is really the standard care in the ICU to see how healthy somebody's brain is. And so an advanced neuroassessment would, of course, include those kinds of things. So we don't want to hurt the patients, of course, but when we're looking for quick answers or if we need to know if the patient's declining, those are the kind of things we need to do. If you're intubated, deep suction will often give you an answer, right? And so you pass the suction catheter down there and they'll grimace or cough, and you can learn a lot. And so when I first come into the ICU in the morning, that's one of the first things I do. And so we can see how they react. Do they open their eyes? Do they give me the evil eye? There's a lot to learn from that kind of stimulation, and you're not going to hurt them, but it's certainly uncomfortable. Okay, so I think that one's pretty straightforward otherwise. Any questions about that, the facial weakness? Okay. So the motor exam, I think generally speaking we do pretty well here. This version recommends you count aloud and you show your fingers, and I do think that's a really good way. You don't have to do that with everybody. If they're awake and they're following commands clearly, you can just say, hold your arm out like this for 10 seconds, I'll count aloud. And they'll usually do it, right? So any movement downward is going to score a 1. If you go down and hit the bed, it's going to be a 2. And I have to remember the rest of the scale myself. If there's just a little movement, you say raise your arm and they can move it a little bit on the bed, but they don't get off the bed, and then that's going to be a 3. And then paralysis will be a 4. So I think people score that one pretty accurately. I will show them what it looks like. I'll say, hold your arm out like this, and that can be helpful too. And again, showing them the fingers can be very helpful. This is one of the cases where posturing will end up scoring too, and we don't think about this. So I see all sorts of documentation from all sorts of nurses when it comes to like traumatic brain injuries and things like that. They'll say withdrawal or this or that, but it's important to recognize these things. So if somebody's doing a flexion posture that looks like this, that's a 4. So that's not going to be a 3 or a 2. If they're extending the arm like this is what extension posturing looks like, although it's closer to the body, mind you. That's also going to be a 4. It just means it's the equivalent of paralysis. So if you're unable to move your leg except in terms of a pure reflex, that doesn't help you. And it's as good as paralysis is the idea. So it can be hard. So how do we figure that out in the neuro ICU? And this is where we have to torture people a little bit again. And so you can start with a tiny pinch. And what we're looking for when we're figuring out if somebody has a reflex or if they're moving with purpose, that's really the question we're asking if they can't follow your commands, right? And so I may pinch here, and if they do this kind of thing and try to throttle me, then I know their strength is good and their purpose is good and their mentation is good. And so if I'm confused and I say, well, they're kind of doing this withdrawal thing, that's a made-up term. That's not really a neurologic term. Nobody really can define what withdrawal is. It's not perfect, but it's not really a reflex. I'll give a pinch in different areas. So almost universally, you'll move away from a noxious stimuli. So I might pinch the arm up here, over here. And if you're really comatose or obtunded, I go right for nail bed pressure. It sucks, and you have to give people a strong stimulus, and you might leave a bruise behind. but it's critical in somebody who can't answer questions or is comatose or is obtunded. And so the nurse may say they've had no movement, and I find, with a stronger stimulus, a reflex, or, you can cut through the mentation, a small pinch, they may be too confused to react. And so this is where we can get some different answers in folks. And you can't be afraid to pinch people in those circumstances. So even in the ER, again, if they're just really out of it, you can give them a pinch. And if they do something that looks purposeful and it's not stereotyped, no matter what you do, then you can be able to score them. So I think in general, for most patients, it's pretty easy. But in the ICU and intubated people, right, it's a lot harder. And if you're comatose, of course, you'll have no movement technically, or maybe posturing at best. Any questions about that? And we don't score people who don't have limbs, right? I do try to score people who have like a BKA, like below the knee or an above the knee amputation, just because it tells us something. And bear in mind, somebody may have an old stroke, right? And their baseline NIH stroke scale is 10. And that really represents no new disability. If they come in and they score a 10 again, it can be very hard to know, of course. But I wouldn't give TPA to that patient. The point is to try to be objective. But you can use some logic when assessing what that number means. A lot of old stroke patients deteriorate a little bit, right? And so somebody who started on a new sedating medicine, or they're very tired, or they're very fatigued, and that can be problematic. And they think they're weaker than they are. They have a UTI, and suddenly they're a little bit weaker on one side. And so we can use a little logic. It's not all scales, but when you're scoring it, just try to be objective. Score what you see. So we can skip past the rest of this, I think. So ataxia. So this question was intended to identify cerebellar ataxia. This is this kind of ataxia. There's no rhyme or reason to it, okay? You're doing things like finger to nose, right? Or you can just sort of watch the movements and sometimes see this. And that's meant to reflect injuries to the brainstem and the cerebellum. People can have coordination problems for other reasons, though. So somebody who has complete anesthesia, lack of any sensation, for example, or very diminished sensation, if you do this kind of thing, they're not getting the feedback you and I think of, right? And so if I close my eyes and you move my arm into a position, I know what position it is, right? We take that for granted, but our joints, how long the muscles are, we're constantly being giving unconscious feedback. And so they may be a little discoordinated. And the same is true for weakness, right? And so if somebody has a little pronation, that suggests weakness. And then you try to do this and they're a little off. That technically shouldn't be scored as ataxia. I'd give you a pass for it because it can be very hard, but if it's just a little bit of weakness, they may do this kind of up and down thing where it looks a little discoordinated. But really it's weakness, not ataxia. And this is one of the weaknesses of the scale. And go ahead and score it if you think it's truly ataxic. We can parse it out later, I think. You don't have to get too concerned, but that's the intention. And this was dropped from the modified version of the scale because it can cause a lot of confusion, okay? But it does point to a different spot in the brain. And so I might be worried about a basilar stroke, for example, where we'd want a CTA in somebody who has that kind of thing going on. Maybe the vertebral artery is occluded. That's the kind of symptom we may see. So paralyzed is 0. I'm glad they put it on here, although it's not really on the rest of the scale. So if you're not moving it, you're not ataxic, okay? Because we're trying to see coordination problems. So I do see that one. Does not understand. So again, this is one where you have to see the symptom to really score it technically. And was that a question? No. So an arm and a leg. So your heel to shin is way off. Your finger to nose is way off. Heel to shin is not a very good test. Finger to nose is much better for looking for this kind of thing. But people just kind of have problems, right, when they're doing this heel to shin business. So this one's relatively straightforward. You can use a pinprick. As a neurologist, I go in there and I just do light touch. These are different pathways. They're actually different nerves that are involved with those different types of sensation. But I think it's generally accurately scored for most people. So a complete loss, technically a 2+ is also 2 modalities of sensation, okay? And that would be like light touch and pinprick or pinch that would also score a 2, although it's not labeled that here. If they have no sensation, then obviously it's gonna be a 2. Coma, unresponsive, it's implied that your sensation and your perception of sensation is impaired, so you'll score this one automatically. If you're truly comatose, you'll score something like 14 points automatically to begin with. So I do think that one's pretty straightforward. This is another time, though, where we're going to check for that extinction business and neglect. So I'll come in and I'll say, does it feel the same on both sides? I'll do face, arm, and leg, and they'll say yes, or they'll say no. And then I'm going to do both sides. I'm going to say, close your eyes if they can, and I'm going to touch both sides. And again, somebody who has neglect, if I touch both, they'll only recognize one. But if I touch each arm or leg individually, they'll recognize it. They'll say left, right, 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 right. That's, again, they're extinguishing that perception of sensation. So again, we're subtly checking for inattention or neglect as we go along in the scale, and it should be done simultaneously with visual fields again and sensation. So language is pretty accurately. Some of this is subjective. How many words that you get wrong, does it make it severe? But I think the idea that if it's super hard to understand them communication-wise, it's going to be a severe aphasia is really the best logic you can have. If you're mute, that's the worst kind of aphasia, when they're not talking and they're not comprehending, and that's going to be a 3. So it's either mild, moderate, or just horrible is the idea when it comes to language. And a coma person, again, is sort of assumed. Of course, they won't be talking, and they're going to end up scoring a 3. So I think, generally speaking, nurses tend to do pretty good with that one. Bear in mind, somebody who's confused is going to score on this as well, right? So not even a stroke. So somebody comes in with an infection or something. Dysarthria, this is one that annoys me because it's where the logic is opposite. And so if they're not talking, you score them a 2. So if they have a horrible aphasia where they can't speak and they don't understand anything, then they actually get scored a 2. So it's one of these exceptions. And I see this as a mistake a lot on these scales. If they utter any word, even if it's just the wrong word, yes, no, and it sounds clear, then it's going to be a 0. So you judge what you're given. And if you're not given anything, you assume it's horrible slurring of your speech. Anarthria implies that things are so miscoordinated in your mouth and your tongue that you can't speak at all. And so that does happen where people have full language. So this is one of those rare exceptions where if you're writing or reading, you would probably do fine, but you just can't get your mouth to get the words out, okay? I think mild and moderate, it's subjective, and what's severe dysarthria, but generally I think those two categories are easy to differentiate. So again, but if they're not talking, it's a 2. And again, if they have a coma, again, this is another automatic one. So if you're intubated or unable to test, then it's going to be a 0. So that's really weird logic, right? It's like you're assuming only in aphasia patients it's going to be a 2. So again, an area of trouble. Now, guess what? We've already checked this one, the extinction and inattention as we went along. So usually we can score this right away. So extinction to bilateral simultaneous stimulation. And a 1 is extinction, either in the visual domain or the tactile domain that we already talked about, where we're touching on both sides and they ignore one side, or similar in the vision if they ignore it again. And 2 is profound heavy inattention. So when it's there and you recognize it, it can be pretty easy. So somebody whose eyes are to the left doesn't mean they're necessarily neglectful. And I do see nurses score that pretty frequently, right? They come in and they're paralyzed and looking to one side. But if you hold up their arm and say, are you weak here? And they'll say, yeah, I can't move it, doc. So they're aware of that side. And then you can do the few other things we did, okay? So these scales are very difficult. As a neurologist, I don't use these pictures, but they can be helpful. I was always entertained by this picture, right? Because it's like some 1950s Valium mother, right? She's like, so it's an entertaining picture. Hammock is a tough one, right? But if you live in the Southwest, you better get cactus. And if you look at the wording, they make exceptions. So people who've never seen a cactus in their life, if they can't name cactus, they may not be in aphasia. So there may be cultural issues or language barriers there as well. And not everybody knows what a hammock is, but the rest of it, generally speaking, they should. Although, again, the pictures look a bit dated. Feel free to use these kinds of things when you're scoring them. If you find it helpful, that's fine. But if they've given you history already, you probably are halfway to scoring them for language and the clarity of their speech, the dysarthria. And so I rarely bother with this stuff because you've been talking to them all along, right? And so if you think it's going to be helpful, go ahead and use it. But I would say it doesn't have to be mandatory. It's never an absolute number, right? So if somebody has a pure aphasia, I had a patient like this a month ago. They scored like a 2 for aphasia and nothing else. And that's just because they just hit the wrong part. That's horribly disabling for a patient. And so I would always give TPA in that context. Again, if it's a very mild symptom, a very mild facial droop, I mean, if they're a runway model or something, that may be horribly disabling, and maybe I would treat them for that reason. But the question we're not trying to answer is what is the number exactly, but is it disabling in any way? That's the better choice. And if people are getting better, by the way, this is sort of an excuse a lot of ER doctors used over the last decade or two. The evidence suggests treating that makes more sense. Some of those people will get better and they go up to the floor and guess what? They go downhill. And so we don't want to miss the opportunity. The sooner we get it in, it's more effective and the safer it is. And so err on the side of treatment. And so when we're in these unclear gray areas, I'll have a conversation. So leave it to the doctors and the neurologists, but call the stroke alert. So if you think it's a stroke, just call it. It's not your job to decide about TPA or not. Let someone else handle that, okay? I mean, you may be at risk, right? And so if you don't call a stroke alert and it's clearly a stroke just because you think they can't have TPA. And remember, we have these catheter procedures. You're not going to see them very often, but they will happen. I mean, I guarantee we'll have an AFib patient non-anticoagulated for some reason, right? And on the floor, they'll have the big one. And so recognizing these syndromes is super important. And it can be difficult. Inpatient stroke alerts are always the most complex and difficult. And so leave it to the doctors to make those decisions. If you have a gung-ho surgeon, the CT surgeons I work with, I had somebody had an open heart bypass and they were like, give TPA because it was disabling. And they said, if there's bleeding, we'll deal with it. So even for the surgery, I'll often try to talk to the surgeon real quick. So at times you can't give it. So another clinical circumstance is cath lab patients. Lots of stroke alerts on cath lab patients. Any cardiologists in the audience? No. Okay. So particularly in our facility where they do a lot of high-risk stuff and we do a lot of clinical trials and stuff, these are higher-risk patients. And so, gosh, maybe once, twice a month, I think we probably have a cath lab. Those are hard, real hard cases because they've been on things like bivalirudin, right, Angiomax, and these other blood thinners. And don't worry about that. Just call it. And we've given TPA. We've done catheter procedures. You know, they talk about arterial puncture sites in the last 7 days, right? But guess what? If it's in the groin, that's compressible. We'll put on those clamp devices and stuff, and I'll give them TPA if I think that's their only option. So that criteria is changing. It's not your job to be aware of all of the restrictions. You can ask the questions, mind you, but that leave it up to the doctor. So you'd really be surprised how often we give TPA. The one that really gets me is the stroke within the last 3 months. So I've given TPA to numerous people with prior hemorrhagic strokes. It makes no sense. If they have an underlying lesion that's going to bleed again, like an AVM in their brain, no, I'm not going to give them TPA. If they have an aneurysm, again, that's one of the things you're not supposed to TPA for. That makes no sense. You're not going to rupture an aneurysm. If you think they're having an aneurysm episode with the worst headache of their life, that's something else. And so routinely we give people TPA now, but you have to ask the question. So if you don't ask the question, you can't give an answer. And even if there's surgery, you'd be surprised. So it depends on the surgeon. Thank you for coming. If you have any questions that weren't answered, email them to Sharice and I'll try to address them.